So let's get started from where we had left in the last session. So this is about heart block. So heart block, as you know, you have first degree heart block, second degree heart block, and third degree heart block. First degree heart block means it is simply PR prolongation. PR prolongation, right? So PR interval is usually less than 200 milliseconds. If it's more than 200 milliseconds, it is called first degree heart block. But what is more important, first degree, is the RR interval is like fixed, and the PR uh, is it's not progressively prolonged, it's fixed but is prolonged, right? So it is taking more time for the impulse to travel from SA node to the AV node and then uh, through the Purkinje fibers and all. So that AV nodal delay is more. So that is what is meant by PR segment. So the PR interval is getting prolonged. In second degree, there are two types. One is called Morbitz type 1 and the other is Morbitz type 2. Morbitz type 1 is also called as Wenke-Bach phenomena. What is Wenke-Bach phenomena? You can see here. This is Morbitz type 1, second degree heart block. You can see that. See, this is P, this is QRS complex. So this is the initial PR interval. In the next thing, what happens? The PR interval is slightly prolonged. The third one, it's even more prolonged. Okay, again more prolonged until one QRS will be dropped here. Here you can see the P. You can't see a QRS here. Okay, no, no QRS here, and then it starts all over again. PR interval again prolonged, progressively prolonged until one QRS will be dropped. That is called Moffitt's type 1 second degree AV block, which is called Wenke-Bach phenomena. Second degree type 2 means some of the QRS is dropped. Okay, second Moffitt's type 2 second degree means some of the QRS is dropped. You can see that here you have a PQRS, but here you have a P no QRS, right? There is no QRS. Here PQRS, PQRS, PQRS is dropped. So there is no fixed intervals at which it is dropped. It can be dropped randomly, or it can be like a 2:1 block or a 3:1 block. That means uh, uh, some of the P will be blocked. So the P will be twice as that of QRS. Okay, every second P will be blocked in 2:1 block. Now, third degree heart block means it is complete AV dissociation. So third degree heart block means it is complete AV dissociation. Complete AV dissociation. That means there is no association between the P and QRS. They happen at random intervals. P will be on its own, QRS will be on its own. So the atria is no longer controlling the ventricular uh, rate and rhythm. They are firing on its own. Okay, that's complete heart block or third degree heart block. Now let's talk about bundle branch block. From bundle branch block, you might have heard the mnemonic Marrow and William. I'll try to make it as simple as possible. So we are mainly looking at the chest leads, okay, chest leads. So V1 and V6. If you can see V1 and V6, uh, the M pattern in V1, W pattern in V6 is called as RBBB, right? Bundle branch block, that is marrow. W pattern in V1, M pattern in V6 is called LBBB, that is left bundle branch block. I'll try to explain how it is happening, okay? So this is the W pattern and M pattern, or it is also called as RSR dash pattern in V1, seen in RBBB, and QRS pattern in V6. In LBBB, it is the W pattern in V1 with M pattern in V6. Okay, I'll try to explain it, okay? So how it is happening? Let's take one example, whether RBBB or LBBB. We'll take RBBB. as an example. What is meant by right bundle branch block? Let's try to make it simpler. So what is happening is you have the SA node, okay, uh, the SA node, okay. So RBBB means we have from the SA node it is coming to the AV, okay, and then it is going where? To the bundle of his and to the right and left bundle, right? Right and left bundle. That's the normal thing. Now there is RVVB. That means suppose this is the right ventricle, this is the left ventricle, and the conduction through the right bundle is blocked. That is what is happening in RBBB. So this is blocked. This is called RBBB, which means right bundle branch block. So there are three rules which you must know. Let me draw that again. This is the right ventricle, the left ventricle, and this is blocked here in RBBB. And there are few things you need to know. That is, first the septum is getting depolarized, and the septum is getting depolarized in the direction of left to right. That is the normal direction of the septum depolarization. Then the ventricles are getting depolarized through the right bundle and the left bundle. The right ventricle comparatively has a lesser lesser, what we can say, the lesser thickness of the ventricle, because the left ventricle has to pump blood through the aorta to the distant parts of body. It has a thicker wall compared to the right ventricle. So the right ventricular voltage will be a little bit lesser, or amplitude will be a little bit lesser than left ventricular voltage. And also there is one thing, when you're looking from one lead, suppose you're looking at V1, whatever is coming towards V1 will be taken as a positive deflection. Whatever is going away from V1 will be taken as a negative deflection. These are the basic rules that we have to follow. Now let's see what is happening here. Okay. Okay, so there is right bundle branch block. So there is nothing going through the right bundle. So let's see what is happening with regards to the V1, the first chest lead. So V1 is looking more towards the right ventricle. V1 is placed more towards the right ventricle. Right? It's a fourth intercostal space, right sternal margin. That's where the V1 is placed. It's looking at the heart in a horizontal plane. The limb leads were looking at the heart in a vertical plane. The chest leads are looking at the heart in a horizontal plane. So V1 is more towards the right ventricle. So whatever is towards that right ventricle will be taken as a positive deflection. So as far as V1 is concerned, when the septum is getting depolarized, the septum, the usual direction is left to right. Here the right bundle is blocked, but the left bundle is okay. So left to right will be normally happening. So that will be a small positive deflection, because left to right means towards the right ventricle, right? So V1 will take it as a positive deflection, but it will be of very small amplitude because it's a septal depolarization. So that's a very small positive deflection. Next, what happens? Next, it has to be like the right ventricle, because it is looking at the right ventricle, but the right bundle is blocked. So the right ventricle will not depolarize first. The depolarization has to go to the left ventricle through the left bundle and then come back to the right ventricle through the ventricular wall. Okay, so first what you will appreciate is the left ventricular deflection. Left ventricular deflection, as far as V1 is concerned, it is going away from V1, right? Because left ventricle is getting depolarized, V1 is looking more towards placed more towards the right ventricle. So it will take it as a negative deflection, and it will be of more amplitude because it is left ventricle. Left ventricle has more thickness, so it has more amplitude. So this will be of left ventricle. Next, what we'll have? You'll have the right ventricle. Right ventricle will get depolarized after the left ventricle through the ventricular musculature rather than the bundle, because the bundle is blocked. So you will have a positive deflection because it is going towards the V1, towards the right ventricle or towards the V1. So it'll be a positive deflection, but it'll not be as high in amplitude as the left ventricular deflection, because left ventricle is more in thickness. So you will get a small positive deflection followed by a big negative deflection followed by a little bit larger positive deflection. And how do you name this deflection? So this is like the M pattern. This is called the M pattern. Okay, this one. This is called the M pattern. Hmm? And how do you name that deflection? Okay, when you have the M pattern, how do you name that deflection? So the rule is, in QRS complex, you are naming it as the first positive deflection is named as R, R wave. And if it's a smaller amplitude, it's called small letter R, and if it's bigger in amplitude, it's called big capital letter R. The first negative deflection is called a Q wave. Okay, first negative deflection is called a Q wave, but there is one thing, that is, first, let me write it here, first negative deflection after a positive deflection, after a positive deflection is called first negative deflection after a positive deflection is called S wave. Okay, so first negative deflection is called a Q wave. First positive deflection is called an R wave. First negative deflection after a positive deflection, that is after an R wave, is called an S wave. And your capital small letter depends on the amplitude. If it's more in amplitude, you write it as capital letter. If it's lesser in amplitude, you write it as small letter. That's a rule. Okay, so we'll try to name this wave that we saw in V1 in case of RBBB. Okay, we have a small positive deflection. So what do we call it? That is R. And it's a small letter R because it's lesser in amplitude. It's a septal deflection, right? Then we have a bigger negative deflection. Any negative deflection after an R wave is called NS wave, and it's capital letter because it is higher in amplitude. So of the left ventricular depolarization, when you're looking at from V1, it seems that it is going away from V1. So it's a negative deflection. Then you have a positive deflection of the right ventricle and it's coming towards V1. So it's a positive deflection. And it's any positive deflection which is coming after is always an R wave. But you have to distinguish it from the first R wave. So you call it R dash and you write it as capital letter because it's higher in amplitude compared to the septal. So it is called RSR dash pattern, or from the appearance you can call it as M pattern. That's how you get M pattern in V1 in RBBB and W pattern in V6 in RBBB. Okay, W pattern in V6 is with regards to this is like the similar principle, because from V6, when you're looking at from V6, the first deflection is going to be the septal depolarization. The septal depolarization is left to right. So when looking from V6, it seems, because V6 is located more towards the left ventricle, so left to right means it's going away. So the septal depolarization will seem like a negative deflection, but it's of smaller amplitude because it is a small negative deflection. Then you have the left ventricular depolarization happening, and when looking from V6, it seems like a positive reflection because it is coming towards the lead, and left ventricle is more in thickness, so it's more in amplitude. So it's a bigger positive deflection. Then you have the right ventricle being depolarized after the left ventricle when it goes through the musculature, and it is slightly lesser in amplitude than the left ventricular depolarization, and it's negative because it's going away from V6. So it's a negative reflection. So it is called W pattern in V6. Hope this is clear. When you hear it for the first time, it seems a bit odd, but this is how it is happening. So you have W pattern in V1 M pattern in V6 in RBBB, or you call it RSR dash pattern in V1. Okay, or this one is the QRS pattern itself. It's a small negative reflection, so it's called a Q wave. A bigger positive reflection is called an R wave, capital R. Then a negative reflection, which is called S wave. So it's QRS pattern. So mainly RSR dash pattern or M pattern in V1. Okay, with the same principle, we get in LBBB exactly opposite. We'll get M pattern, W pattern in V1 and M pattern in V6. Hope that is clear. This is how you get RBBB and LBBB. Now we'll have certain other criteria from ECG. One is LVH and RVH criteria. LVH criteria, we say that it is the bigger deflection in V1, that is S wave. In V1, it's usually S wave, because V1 to V6, what we get is R wave progression. So R wave is slightly smaller in V1. We have a bigger S. So it is actually S wave in V1 or V2, whichever is bigger, plus R wave in V5 or V6, whichever is bigger, the sum of which comes out to be 35 mm or 7 big squares. 7 big squares. That is a criteria for LVH. RVH criteria is right axis deviation along with an R wave in V1 more than 7 mm. Usually R wave in V1 is very small, but if it turns out to be large, it means it is a right ventricular hypertrophy. You can see that it's of two big squares here. V1R is two big squares. Two big squares means it is almost more than 7 mm, right? Then here you have uh, this one here, V1. This is three big square, and V6 or V5 also. You can see 1, 2, 3, and 4. That's more than 7 big squares or 35 mm. Okay, there are few other ECG findings. Let's try to find out what this is. I'll zoom it in and you try to say. What is happening here? Look at the ECG, don't look at the diagnosis first, right? Okay. Okay. Here, you have, can you appreciate the P here? This is P. Okay, this is QRS. Then you have a T. Then you have a P. Okay. Mm, but you can't find and it is highly prolonged. You can't find exactly you need a actual long strip to find out. Okay. But there is no actual association with P and QRS. Here you have a P, but you don't have a QRS. Then you have a P again, okay, and then you have a QRS. That means there is no association between P and QRS. That's complete AV dissociation or third degree heart block, also called as complete heart block. Then what is this that you see? This is the isoelectric line, right? There is ST elevation here, and um, there can also be something called a PR depression that you can see in here. So that is called pericardial effusion. Pericarditis, you get PR depression. Pericardial effusion, you can get low voltage electrical complexes. You need actually a long rhythm strip or a long ECG to actually diagnose this. Otherwise, there are some classic findings that you can see here. This is ST elevations. Okay, very hard to miss, right? ST elevation MI. Peak T wave, where do you get? In hyperkalemia. Then inverted T waves, where can you get? Inverted T waves, you can actually get an strain pattern, acute ischemia. Then inverted T wave can be in late stages of pericarditis. Okay. Then Brugada's sign. Brugada's sign is code ST elevation more than 2 mm. Okay. In V2, V3 and all. That's called Brugada's sign. A part of Brugada syndrome, which can predispose to sudden cardiac death. Then wide QRS interval. Then Mobitz type 2. Mobitz type 2 means some of the QRS are like dropped. It can be Mobitz type 2 second degree heart block. That means some of the QRS are dropped. Okay. Then again, This is Mobitz type 1, that is progressive prolongation of PR interval until one QRS is stopped and then it starts again. HOCM, what do you usually get? Hypertrophic or obstructive cardiomyopathy. There can be deeper T wave inversion with dagger Q waves and all. Okay. Then ST depression you can see in ST elevation MI. Arrhythmogenic right ventricular dysplasia, you get a small wave like that. Okay, epsilon wave. It's called epsilon wave. The WPW syndrome, you get a slurred QRS along with a short PR interval. This is a pathological Q wave. You can get an old MI. J wave or Osborn wave are part of hypothermia. It's seen in hypothermia. QT prolongation in drugs predisposing to QT prolongation, which can predispose to tortuosity pointers. So you have to be careful while giving those drugs, like azithromycin. There are antiarrhythmic like amiodarone, sotalol, anti-epileptic like levetiracetam, and ondansetron and all. Okay. Now, classical ECG findings I have added again. Hypothermia, get an Osborn wave. Sometimes it can be asked as an MCQ where they ask what is seen in hypothermia. It's called Osborn wave, also called as J wave. J wave. Then hyperkalemia. What are the findings in hyperkalemia? Initial finding is going to be tall peaked T waves. Okay, then you can have a squaring of the P wave, then absent P wave, right? Then you have finally there is called sine wave pattern, sinusoidal wave or sine wave pattern. So you don't wait for sine wave pattern to appear to correct hyperkalemia, because by that time the patient would be gone. Okay, because that is going to be malignant hyperkalemia where you cannot do anything anymore. Okay, so you have to intervene early itself. Peak T wave, you get wide PR interval with squaring of P wave, then absent P wave, and wide QRS duration. Then okay, and then finally sinusoidal wave. Sinusoidal wave and all means there is more than 8 to 9 uh, potassium level. Okay, this is in ARVC and all. You can see this. This is about WPW syndrome where there is a delta wave or a slurred QRS with short PR interval. So let's come to angina. So we have covered heart block, we have covered types of heart block, bundle branch blocks, and different ECG findings that you see in different cases, in electrolyte abnormalities as well as other special cases. Now let's come to angina and MI. What is angina? It's going to be chest pain. In simple language, it's chest pain. But what is happening? There is a demand supply mismatch of oxygen, right? Demand supply mismatch of oxygen. So either due to hypertrophy or due to ischemia, there is a mismatch between the demand and supply of oxygen to the ventricular wall. So there you'll get chest pain. Uh, okay, that is called angina. And the angina can be classified into stable, unstable, and variant angina. Stable angina means you have chest pain during exertion only, but it relieves with rest and it relieves with nitrates. Unstable means there is chest pain, but it is not relieving with rest, and you are taking an ECG. There can be ECG changes like ST depressions during ST depression or elevation during the chest pain. It may revert back to normal, but the troponins become negative. So there is no actual infarct which has happened. Variant angina, it's due to coronary vasospasm, so it's coming and going, and it can happen at night as well. And the treatment of choice for vasospastic um, variant angina is calcium channel blocker, because it is like similar mechanism to Raynaud's phenomena. In Raynaud's also this is happening and you're treating it with calcium channel blockers. For other anginas, usually you are not preferring calcium channel blocker. So in stable angina, there is just atherosclerosis. In unstable angina, there is atherosclerosis with blood clot, but there is no complete occlusion. This is coronary vasospasm. In ST elevation MI and non-ST elevation MI and all, there is actual occlusion. In ST elevation MI, there is complete infarct-like thing. That is why you have to intervene fast so as to save the heart. How do you treat angina? The major thing that you give for quick relief is going to be nitrates, sublingual nitrates. Otherwise, if a patient comes with angina, you have to start them with certain drugs like dual antiplatelet, aspirin with clopidogrel, beta blockers. Beta blockers again has a mortality benefit post MI, also in angina. Statins, atorvastatin, because atherosclerosis is the predisposing factor. Variant angina, treat with calcium channel blocker. If it's not responding to any of this, you can try ranolazine. There are some combinations you should be aware of that you should avoid in patients. Calcium channel blocker and beta blockers should not be given for the fear of complete heart block, because both can lead to AV nodal block and both can lead to severe bradycardia as well as complete heart block. Nitrates with sildenafil, because some patients may take sildenafil over the counter, off label, off prescription for erectile dysfunction and all. So it's better that you take a history of that before giving nitrates, because they can go for profound hypotension if they are given a combination of sildenafil along with nitrate. Okay. Now, what is syncope? Cardiac syncope. There is transient loss of consciousness secondary to cerebral hypoperfusion. Okay, it is of rapid onset, short duration, and there is spontaneous recovery. How do you uh, classify syncope? It can be due to decrease in cardiac output or decrease in peripheral resistance. Decrease in cardiac output again can be of cardiac etiology or due to hypovolemia, like in hemorrhage and GI losses. Cardiac etiology can be due to severe aortic stenosis, not the initial part of aortic stenosis and all. Symptomatic aortic stenosis where the patient would require aortic valve replacement. HOCM, pulmonary hypertension, pericardial effusion, arrhythmias. Decrease in peripheral resistance can be due to drugs, can be due to increase in parasympathetic tone like vasovagal, situational, or carotid sinus syndrome. Now, what is vasovagal syncope? It can be due to emotional stress, sudden pain, anemia, fasting. There can be a pre-syncopal feeling. It's usually common in young people. Whenever you have a syncope, try to rule out more important, more severe or more fatal causes like cardiac causes. Just get them done with an ECG, an echocardiography, so that you rule out major structural or any abnormalities with the heart. And then vasovagal, because it comes like a diagnosis of exclusion. You can't comment that this is going to be vasovagal just because the patient is young. Try to rule out structural causes and take a ECG and echo as a basic investigation. So that was a point of discussing syncope. What are the findings you can get in ECG in MI? Mainly we're talking about ST elevation MI. ST elevation MI, the initial finding is not ST elevation, it's peak T wave. Okay, acute ischemia, you get peak T wave. ST elevation takes around 2 to 3 hours. Then there can be T wave inversion, which takes 8 to 12 hours. Pathological Q wave appears 24 to 48 hours later and it stays there. So in old MI also you get pathological Q wave. Okay, pathological Q wave means like a deep and broad Q wave, because Q wave is usually smaller than one small square. Okay, if it's taking more than one small square, that means it is a pathological Q wave. Now, this is another important slide I want you to focus on. Based on ECG, based on ST elevation, where it is present, you can localize the lesion into which artery and which site. Okay, so 2, 3 AVF. 2, 3 AVF, because we have already drawn the diagram for cardiac access. If you don't remember, please go back and listen to that. We have drawn this diagram. So 2, 3 AVF is coming to the inferior side, right? So this is called inferior MI and it is supplied by the right coronary artery. 2, 3 AVF, if there is ST elevation, there will be a reciprocal ST depression in the other leads, but we are not bothered about that. We are mainly concerned with ST elevation, right? ST elevation 2, 3 AVF, it's inferior wall MI supplied by right coronary artery. Right coronary also supply the SA node. Okay. So there can be bradycardia, there can be heart blocks in case of inferior wall MI. And right coronary also supply the right ventricle. So there can be RVMI also, right ventricular MI. Why is RVMI important? Because RVMI is a preload dependent MI. You have to give plenty of fluids, okay, liberal amount of fluid to the patients so as to revive the patient. Otherwise, since it's preload dependent, if you are just intervening the patient without giving any fluid prior to angioplasty, the patient may die on table. Okay, so that is inferior wall MI. Then V1 to V2, V1 and V2 you can write here. So that's going to be anteroseptal. V3, V4 is going to be proper like anterior. Then V5, V6 is like lateral or high lateral. Okay, then there is one AVL which is also lateral. So one AVL V5, V6 is going to be lateral, mainly supplied by the left circumflex artery. Anteroseptal, that means V1, V2, V3, V4, that is going to be left anterior descending artery, and again a branch of left coronary artery. So usually the AV node, SN node is supplied by the right coronary, that's called right predominance. Sometimes in rare cases it can be supplied by left coronary also it's called the left predominance, but usually it's in inferior wall MI where you see sinus brady and you can see heart blocks and you can have right ventricular MI which is preload dependent. So that is how you know diagnose it from the ECG itself. These are the cardiac biomarkers, and this is the time by which they rise. And the main marker that you are concerned about is troponin. Okay, troponin rises early and it stays for about a week. But another nice marker is CKMB, and that is mainly for reinfarction. So if a patient is admitted with ST elevation MI, 2 days later they complain of again chest pain. So you're worried that if it's a new onset, a second recurring MI. So you can't do a troponin now because troponin will be elevated for sure because they already had an MI 2 days prior. It takes around a week for troponin to fall back to normal. So you can do a CKMB for reinfarction. Okay, so for reinfarction, the cardiac biomarker is CKMB. Myoglobin is not a specific marker, but it is the earlier one to rise. Otherwise, if in the option you have troponin and CK and all, which is a more sensitive marker, you can always choose troponin I. Now, how do you manage the patient? First, you manage their pain. You give morphine, you give oxygen. Earlier, it was said you give oxygen to all patients, but now you are keeping a target of SpO2 of more than 94%. If it's less than 94%, you can give oxygen. You can give nitrates for pain relief and aspirin to the patient. But ST elevation MI and ST elevation MI management is slightly differ. In ST elevation MI, the window period is slightly 4 to 4.5 hours, and you are trying to, you know, re-establish the blood flow to the patient. So you have to do a percutaneous coronary intervention. That is called angioplasty. That is the treatment of choice for ST elevation MI. So if the question says the patient is brought with ST elevation MI, sometimes they mention ST elevation MI, sometimes they give the symptoms like they have chest pain and they are brought to the hospital and the ECG is showing ST elevation and the chest pain has started some 3 hours prior. You don't have a facility to do PCI and you have to transfer them to a hospital which might take more than an hour to transport them. What will you do at this point? So at this point, if you cannot reach them to a hospital which can provide them PCI within the window period, that is 4 to 4.5 hours, you may do a thrombolysis and then transfer the patient. Otherwise, if you can transport them within that window period, always prefer PCI over thrombolysis. NST elevation MI, NSTEMI, you give heparin. Post MI management, there are certain drugs you give. Now, AC inhibitors, beta blockers are a must. Both have mortality benefits, but if you are asked to choose one, you may choose, sometimes in questions they give only one among AC inhibitors and beta blocker because they both have mortality benefit. But beta blockers are usually avoided in acute cases, you only give once they are discharged. So in that case, you can choose AC inhibitor. In acute heart failure, in acute MI and all, you are avoiding beta blocker. Okay. Then you must give statins and a dual antiplatelet cover. Now, what are certain complications of MI in the early post MI period and late? In early MI period, the most common complication is going to be bradycardia and heart block, but the most fatal complications is arrhythmias. Okay, they can have heart failure as well. Arrhythmias, and this is the cause of death. Cause of death in patient immediate post MI is arrhythmia. Fatal arrhythmias like VT, they can go in for VT, and they can die. They can go in for cardiogenic shock, RV infarction, it's preload dependent. So unless and until you give them enough fluid, they might not be saved. Then there can be pericarditis. There can be an immediate post MI pericarditis or long term, immune mediated pericarditis, that is called Dressler syndrome. Post MI pericarditis called Dressler syndrome. Then, since they may be immobilized for longer time, they can have DVT or pulmonary embolism. Then there is papillary muscle dysfunction, papillary muscle rupture, which can lead to MR. So new onset murmur of MR, okay, post MI. Always think of papillary muscle rupture. MR murmur is going to be a systolic murmur, right? Ventricular septal rupture, there can be pansystolic murmur and sudden cardiac failure in the post MI period. Ventricular free wall rupture can lead to cardiac tamponade and can be again fatal. The patient may die. Ventricular aneurysms also can be there. Now, what are the complications of PCI? There can be rupture of coronary artery, there can be restenosis or stent thrombosis or hematoma. Now, right ventricular MI, I have talked about it already. It's an RC occlusion associated with inferior wall MI. Nitrates will be contraindicated in here. Why? Because it's already preload dependent. When you're giving nitrates again, there will be hypotension, hypovolemia. So you have to avoid nitrates. The lungs are usually clear because there is hypovolemia in RVMI. Impaired RV filling, so it's a preload dependent. Fluids should be administered. So give fluids but do not give nitrates. Then cocaine-induced coronary ischemia. This has been a previous question. So what is happening is it's like a sympathomimetic, so there can be coronary vasoconstriction. In acute cases, the treatment of choice is IV benzodiazepines, but you're mainly avoiding beta blockers. So if in the options, like there is a patient who is a chronic cocaine abuser coming with some cardiac symptoms, angina-like presentation, you may be asked, how do you manage this patient? If in the option you have beta blocker, try to avoid that. Okay, it's either IV benzodiazepines, you may give nitrates and antiplatelets also. But if it's presenting like ST elevation MI, then treat like ST elevation MI. You can go for PCI. Okay. Then, what about cardiac arrest? Cardiac arrest, you have the ACLS protocol. If you're classifying it into shockable rhythm versus non-shockable rhythm. So, what are your shockable rhythms? Shockable rhythm is pulseless VT, because VT can be with pulse or without pulse. For with pulse, you have to treat like an unstable VT. You may go for synchronized cardioversion. But otherwise, you can give a shock or defib because the voltage is different, and that is why you are calling it as defib and synchronized cardioversion. Synchronized cardioversion is synchronized to the cardiac cycle. Okay, the other one is not synchronized, right? Pulseless VT and VF are the shockable rhythm. What are the non-shockable rhythm? That is pulseless electrical activity and asystole. Okay, then you follow the ACLS protocol. You're giving IV adrenaline, and then you're giving a shock in case of shockable rhythm. After 3 consecutive shocks, you're going for anti-arrhythmic like amiodarone. Okay, there is a strict protocol to follow for that. Now you have to always rule out the reversible causes of cardiac arrest in that ACLS protocol. That is 5H and 5T: hypovolemia, hypothermia, right? The electrolyte abnormalities, hypokalemia, hypoxia, and acidosis. What are the 5Ts? Tamponade, tension pneumothorax, then thrombus, that can be a cardiac thrombus or Uh, okay, and those are the 5H and 5T. Okay. Next, coming to heart failure. Heart failure, you can classify them on, on different basis. It can be a systolic versus diastolic failure. Systolic can be due to reduced ejection fraction, and diastolic is the ejection fraction will be preserved, but you are having less diastolic filling, so that you have less cardiac output. But the ejection fraction will be preserved, because ejection fraction is stroke volume divided by end diastolic volume. In diastolic failure, both of this will be reduced, so the ratio will remain constant. But in systolic failure, the stroke volume will be reduced, but the EDV will be comparatively normal, because you are not able to contract and push out the blood. Then it can be a right versus left ventricular failure. It can be a low high output versus high output failure. High output failure you usually say in case of anemia, thyrotoxicosis, right? It can be cold versus warm, that is based on the peripheries, whether it's cold or warm. Warm shock usually in septic shock. Cold shock usually in cardiogenic shock. Hmm. Wet versus dry, based on the lung findings. Okay, if there is pulmonary edema or not. And it can be acute versus chronic. Now, why are you classifying this? So that you can manage. Mainly, you will be concerned with this cold versus warm and wet versus dry. So, if you are having a wet heart failure, you have to give IV furosemide, right? IV diuretics. And if it's cold, you have to give inotropes that can pump the blood. Okay, so that is like the management. Again, there are four classes. Class 1 means there is no limitation, no symptoms in ordinary physical activity. Class 2 means slight limitation. Class 3 means marked limitation. Class 4 means severely limited. Even at rest, there is heart failure symptoms. They are having orthopnea. They can't, they're having severe dyspnea. They can't walk. Even 100 meters they cannot walk. There is Killip class. Again, that is class 1 is no signs of heart failure. Class 2 means there is crackles in lungs, that means pulmonary edema, with S3 gallop, that is left ventricular failure with raised JVP. Class 3 means raised JVP means right heart failure, right? Acute pulmonary edema in class 3. Class 4 means it's a cardiogenic shock. So there is cold peripheries and all. So this is the X-ray. This has been a previous question. What do you see in case of pulmonary edema? There can be pleural effusion. There can be increased cardiothoracic ratio because of cardiomegaly. Okay. How do you say cardiothoracic ratio? You take the maximum distance from the midline towards the right as well as towards the right. It's not going to be a straight line. It's going to be at two different points. And that total distance, when compared to the total thoracic volume, if it's more than 0.5, that means it is taking more than half the area. It's called cardiomegaly. Then cephalization of the vessels and curly B lines, that is horizontal lines running, that is called curly B lines. These are all findings in pulmonary edema or heart failure. Now, how do you manage heart failure? Heart failure management is important because mostly the question comes like, what are the drugs which can have a mortality benefit? So, mortality benefit mainly with AC inhibitors along with beta blocker. Okay, but AC inhibitor it's contraindicated, like there is severe cough, angioedema due to AC inhibitor use. You may go for ARB. Okay, ARB is angiotensin receptor blocker. Otherwise, if you can't give any of those, you can give a newer drug which is called ARNI, that is ARB along with neprilysin inhibitor. Neprilysin inhibitor. Neprilysin inhibitor. Okay, that is sacubitril plus valsartan. Plus valsartan. Valsartan is an ARB, sacubitril is a neprilysin inhibitor. Can give beta blockers. Usually we are giving metoprolol succinate. Okay, there is metoprolol, tartrate, and succinate. Succinate is given in heart failure. Then spironolactone nitrates, dapagliflozin. Dapagliflozin is actually Oral hypoglycemic agent, it has cardiac benefit as well as renal benefit. So it's usually started early on in diabetic patients so that you're having like prophylactic benefits. Okay. Then furosemide, digoxin, ibuprofen can be added in resistant cases if it's not treated with other drugs, but they're not having mortality benefits, right? All the other drugs like ACE inhibitor, beta blockers, spironolactone, nitrates, DAPA, they all have proven mortality benefits. Now, digoxin toxicity. Since we have talked about digoxin toxicity, the digoxin is a like a again narrow therapeutic index, so it has to be monitored because other electrolyte abnormalities can also predispose to digoxin toxicity. Hypokalemia increase the risk of digoxin toxicity because digoxin also act on sodium potassium channel. So if there is hypokalemia, it will act more and there will be more toxicity. There can be conduction defects, there can be vomiting, diarrhea, and altered color vision, like yellow color vision. Okay, that's called xanthopsia. And this is what you can get like a reverse tick sign. It's called a reverse tick sign in case of digoxin. Reverse tick sign. Well, let's come to cardiomyopathy, but I think we'll discuss that in the next session because we'll be having a few more topics to cover. We'll cover that in the next session. That will cover the cardiology for EMREE. So, all the best for all of you who are preparing for this cycle. Thank you so much.